Usually when we think about a runny nose, we treat it as, well, just a minor, slightly boring inconvenience.
Yeah, totally mundane.
Right, you grab a tissue, blow your nose, and just move on with your day. It is the absolute definition of mundane. But today, we are looking at a stack of incredibly dense clinical data and medical research that, honestly, it completely shatters that illusion.
Oh, absolutely.
Because what we are exploring today is the sheer structural and immunological chaos that can happen inside the human face. We are looking at a microscopic war zone.
It really is a massive shift in perspective.
Yeah.
When you start digging into the actual anatomy and pathology of the nasal cavity, you realize it isn't just some simple hollow tube for air to pass through.
Right.
It's an intricate high-security border crossing. I mean, it is the literal frontier between your brain, your lungs, and the unsterile outside world. And when the security at that border fails, well, the consequences are anything but mundane.
Exactly. So our mission for this deep dive is to decode this complex clinical information and reveal the secret, high-stakes battles happening right behind your face. We're talking about actual brain fluid leaks, impenetrable bacterial bunkers, and extreme fungal allergies that look like something out of a sci-fi movie.
It gets wild.
It really does. Okay, let's unpack this, starting with a condition called CSF rhinorrhea. Because sometimes, a runny nose is not mucus at all. It is literally your brain leaking.
Which is a terrifying concept, but anatomically it makes perfect sense. The roof of your nasal cavity is actually the floor of your skull.
Wow, okay.
It has a very thin structure called a cribriform plate, and it almost looks like a piece of porous bone sponge. And directly above it sits your brain, which is floating in serum or spinal fluid, or CSF.
Right, and the notes mention your body constantly maintains a volume of about 150 milliliters of this fluid.
Kept under specific pressure, yeah. About 50 to 150 millimeters of mercury.
And when there is a structural bony defect, like a literal crack in that floor, that pressurized fluid has to go somewhere. The data shows this can happen from a traumatic injury, a previous surgery, a tumor, or even spontaneous intracranial hypertension.
Right, where the pressure inside the skull just builds up on its own.
Exactly. So the fluid finds the path of least resistance, which is right down through the cribriform plate and out your nose.
Precisely. And the immediate challenge for a clinician is differentiating between a standard viral runny nose and a highly dangerous skull-based leak. Because, well, one requires a tissue, and the other requires urgent neurosurgical intervention to prevent an infection of the brain.
The diagnostic detective work here is fascinating, though. There are a few major physical clues. First, there's something called the halo sign.
Oh, the halo sign's a classic.
Yeah, if the fluid drips onto a cloth or a pillowcase, the heavier components stay in the center, and the clear CSF rings around it, expanding outward like a halo. And there's another beautifully simple physical detail. Unlike normal mucus, CSF can't be sniffed back.
Right, it just freely constantly drips. Because it completely lacks the viscosity and proteins of mucus. I mean, it's essentially the consistency of water.
Wow.
But physical signs aren't enough to rush someone into surgery, which is why you have to prove chemically that the fluid is actually from the brain.
Right, and they start with glucose testing. Normal nasal discharge has very low glucose, usually less than 10 milligrams per deciliter, but CSF is rich in glucose, usually greater than 30. But honestly, testing for glucose feels like using a crude metal detector.
That's a good way to put it.
Sure, it tells you something might be there, but it's not definitive. There's a much better test highlighted here, which is checking for beta trace protein. It's like checking for a highly specific VIP pass.
That is the gold standard. Beta trace protein is an enzyme produced almost exclusively by the meninges, the membranes that wrap around the brain and spinal cord.
So it's definitive.
It is a biological fingerprint. If you find beta trace protein in nasal fluid, you have absolute confirmed proof that the border between the brain and the outside world has been breached.
But knowing there is a leak is only half the battle, right?
Exactly. You still have to find exactly where that microscopic crack is located. Is it in the ethmoid roof, the frontal sinus, the sphenoid? Because you simply can't repair a hole you can't see.
Which brings us to the craziest diagnostic test in this entire stack of research. It's called intrathecal fluorescein.
It is highly effective, but quite a dramatic procedure.
Dramatic is an understatement. Let's walk through exactly how wild this is. Doctors take 0.1 milliliters of a 10% fluorescein dye, dilute it in 10 milliliters of the patient's own spinal fluid, and then slowly inject it directly into the spinal canal over 10 minutes.
Right.
Then they take a specialized blue light filter, stick an endoscope up the patient's nose, and look for a glowing, bright green neon leak dripping from the roof of the cavity.
It creates a brilliant visual contrast.
Yeah.
You absolutely cannot miss a glowing green drop of liquid against pink tissue.
Wait, I need to pause you there, because the clinical literature explicitly states this dye is not approved by the FDA for this specific use. And right below that, the major side effects listed are hypersensitivity and seizures.
Yes, that's in the nose.
Why on earth would anyone agree to this? Why would a doctor inject an off-label chemical that can cause seizures directly into someone's spinal fluid just to find a drip?
It is a significant clinical decision, absolutely. But you have to weigh the risks of the intervention against the risks of the disease.
Okay, fair.
A continuous CSF leak means there is a permanently open doorway from the unsterile bacteria-filled nasal cavity straight into the fluid surrounding the brain. If a single strain of bacteria walks through that door, the patient develops meningitis, which can be rapidly fatal.
Oh wow, so it's a huge risk.
Huge. Despite the risks of the fluorescein dye, it is incredibly effective for localizing the exact anatomical defect. Finding the glowing green leak guarantees a successful surgical repair. The transient, statistically low risk of a seizure is considered an acceptable trade-off to prevent a lethal brain infection.
High stakes, high reward. And if they find a leak, how do they actually fix it? The clinical pathway mentions conservative management first, like 10 days of strict bed rest, elevating the head. But the one that really stood out to me was the prescription of stool softeners.
Ah, yeah, that comes down to pure physiological mechanics. Think about what happens when you strain. You perform what's called a Valsalva maneuver.
Which is when you bear down, right?
Exactly. That massively increases your intra-abdominal and thoracic pressure. That pressure restricts blood from draining out of your head, which transmits right up your venous system and increases your intracranial pressure.
So a sudden spike in pressure inside the skull could easily blow out a delicate, newly forming blood clot at the site of the skull base leak.
You've got it. It's all connected.
Man, if conservative management fails, they have to go to surgery to patch the hole. And the grafts they use to plug it are fascinating. If it's a small trauma leak, they might just take a single layer of mucosa from inside the nose.
Very straightforward.
But for larger spontaneous leaks, they build multi-layer sandwiches. They take the patient's own abdominal fat, pieces of cartilage from the nasal septum, or even allografts like bovine collagen. Wait, bovine collagen is processed cow tissue, right? How does a human skull accept cow tissue to patch a brain leak?
It works because of how the material is processed. It's in a cellular dermal matrix. They take the bovine tissue and completely strip away all the living cells, leaving behind just the structural collagen matrix.
So the body doesn't freak out.
Exactly. Because there are no cells, the human immune system doesn't recognize it as foreign tissue, so it doesn't attack or reject it. Instead, it acts as a perfect biological scaffold. The patient's own cells migrate into that cow collagen matrix and eventually grow their own solid tissue right across the gap.
That is incredible. So structural leaks like CSF rhinorrhea are a macro-level failure of the nose architecture. We're basically fixing a broken ceiling, but what happens when the bone is perfectly intact but a microscopic war breaks out on the very surface of the tissue itself?
That takes us into a completely different realm of pathology. We move from structural failures to chronic inflammatory cascades.
Right, and that brings us to chronic rhinosinusitis, or CRS. Now, to be clear to you listening, this isn't a temporary cold. The diagnostic criteria are incredibly strict.
Very strict.
To have CRS, you need 2 or more primary symptoms, like severe nasal obstruction, discolored discharge, facial pain, or a total loss of smell. And these symptoms have to last for more than 12 uninterrupted weeks.
That is 3 solid months of misery.
And it has to be backed up by physical proof, like positive findings on an endoscopy or a CT scan.
It severely impacts a person's quality of life. Clinicians actually track the severity of this condition with a validated assessment tool called the SNOT-22 score.
I love that name. SNOT-22. It sounds like a bad punk band.
It really does. It stands for the Sino-Nasal Outcome Test. It's 22 specific items that measure not just the physical symptoms, like the need to blow your nose or facial pressure, but the emotional and sleep-related toll.
Oh, so it asks how often the patient wakes up tired, how frustrated or irritable they feel, and how much their productivity is dropping.
Exactly. It quantifies the misery. And pathophysiologically, CRS splits into 2 very distinct microscopic bouts.
Okay, let's break those down.
First, you have CRS with nasal polyps, abbreviated as CRS-WNP. This is an explosive inflammatory battle driven by T2 helper cells, resulting in massive eosinophilic inflammation with huge spikes in interleukin-5 and IgE antibodies.
Okay, hold on. You just threw a lot of immunology at me. Let's translate that. What is a T2 helper cell doing, practically, and what are eosinophils?
Fair enough. Think of T2 helper cells as military generals in your immune system. Their specific job, evolutionarily, is to coordinate attacks against large parasites like worms.
Okay, but there aren't worms in the nose.
Right, but in CRS-WNP, these generals get confused. They misidentify a harmless trucker in the nose as a massive threat, so they call in the eosinophils, which are essentially the heavy artillery cells of the immune system.
And the interleukin-5.
The T2 cells release interleukin-5, which is like an accelerant. It tells the eosinophils to dump their toxic proteins all over the nasal tissue. The tissue gets so damaged and swollen from this friendly fire that it literally fills with fluid and sags down into these grape-like growths called polyps.
So the polyps are essentially water balloons of inflamed, damaged tissue caused by a confused immune system.
Exactly. And on the flip side, you have CRS without polyps, or CRS-SNP. This battle is commanded by T1 helper cells, and instead of eosinophils, it uses neutrophils.
No water balloons.
No, the result isn't a swollen grape-like growth. Instead, it causes a hardening of the battle seal. The basement membrane of the tissue thickens and develops fibrosis, which is essentially widespread scarring.
But regardless of whether a patient has polyps or scarring, the notes highlight one massive obstacle that makes treating chronic sinus infections incredibly difficult.
The biofilm.
Ah, yes.
Biofilm.
Biofilms sound like something out of a science fiction movie. The research defines a biofilm as an aggregate of bacteria protected by a proteoglycan shell. I was trying to picture this, and it really sounds like the bacteria are building a hardened bunker, or, turning on a deflector shield.
Your bunker analogy is highly accurate. When bacteria are floating around freely in your body, what we call a planktonic state, they are highly vulnerable to standard antibiotics.
Makes sense.
But bacteria have a survival mechanism called quorum sensing. When enough of them gather in one place, they communicate chemically. They realize they have the numbers, so they group together, anchor themselves to your nasal tissue, and excrete a thick, slimy matrix made of sugars and proteins.
The proteoglycan shell.
Right. Once that shell hardens, the resistance to antibiotics can increase up to 1,000-fold.
Wait, really? 1,000 times more resistant because the drug physically cannot penetrate the slime layer.
Exactly. You can flood the patient's system with oral antibiotics, and medication just bounces right off the bunker.
So how do you bust a bacterial bunker? The medical solutions used here are wild. First, doctors try high-volume irrigation, literally pressure washing the sinuses with saline.
Which is a good start.
They add antibiotics directly into the wash, like tobramycin or mupirocin, specifically if the bunker was built by Staphylococcus aureus. But when those fail, the treatments take a very unconventional turn to break the slime.
Clinical desperation often breeds innovation. When standard molecular drugs fail to penetrate a biofilm, you have to look for compounds that alter the physical environment.
And alter they do. The clinical literature lists using colloidal silver sprays. They list Manuka honey specifically at exactly 1.8 milligrams per milliliter concentration, which apparently creates an osmotic pressure that just sucks the water right out of the bacteria.
Fascinating.
And then my absolute favorite intervention in the entire stack, prescribing high-volume sinus irrigation with Johnson's baby shampoo. I mean, a doctor telling a patient to put baby shampoo up their nose to cure a hardened sinus infection.
It sounds absurd, but the science behind it is actually brilliant. What is baby shampoo at its core? It's a mild surfactant.
Okay, surfactant.
Think about washing a frying pan covered in stubborn baked-on grease. If you just run plain water over it, nothing happens. The grease repels the water. But the moment you add a drop of dish soap, which is a surfactant, it breaks the surface tension.
It chemically emulsifies the grease so the water can easily wash it away.
Exactly.
Oh, so the baby shampoo acts exactly like dish soap for the bacterial bunker. It breaks down the surface tension of that thick proteoglycan shell, so the body's immune cells or the antibiotics can actually reach the bacteria inside.
Precisely. It chemically dismantles the biofilm's defenses.
Yeah.
And they use a tear-free baby formula because it's gentle enough to break down the bacterial slime without irritating the delicate human mucosa underneath.
That is genius. So bacteria build forts and we bust them with baby shampoo. But as we move deeper into the pathology, we see that sometimes the nose's worst enemy isn't a bacterial invader at all.
No, sometimes much closer to home.
Right, sometimes it's the body's own immune system launching an absolute scorched earth campaign against things that shouldn't be dangerous at all.
This brings us to conditions that fall under the umbrella of severe systemic immune overreactions that happen to manifest in the nasal cavity. Two extreme examples really stand out in the nose: AER and ARFRS.
Let's start with AER, which stands for aspirin exacerbated respiratory disease. The mechanisms here are fascinating. A patient takes a completely normal dose of aspirin, and their body reacts by having a massive asthma attack and immediate severe sinus inflammation.
It's an acquired metabolic intolerance. To understand why it happened, we have to look at the cyclooxygenase pathway, which is completely hijacked.
Let's translate that for everyone. What is the cyclooxygenase pathway, and how does aspirin hijack it?
Think of it as a metabolic intersection inside your cells. When your body's dealing with inflammation, a chemical called arachidonic acid travels down the road and hits a fork.
Fork in the road.
It can either turn left down the cyclooxygenase or QOX pathway, which produces prostaglandins that actually help regulate and calm down inflammation. Or it can turn right down the lipoxygenase pathway, which produces leukotrienes. And leukotrienes heavily promote inflammation and swelling.
Okay, so a left turn regulates things and a right turn causes swelling. Where does the aspirin come in?
Aspirin works by putting up a permanent roadblock on the left turn. It blocks the COX pathway. For most people, that just relieves a headache. But in patients with AERD, blocking that left turn forces all of the chemical traffic to turn right.
Oh, no.
Yeah, their body dumps massive, overwhelming amounts of leukotrienes into their system, creating a catastrophic inflammatory traffic jam that immediately closes up their lungs and sinuses.
That sounds miserable, but the fix for it, the extreme fix detailed in the research, is mind-boggling. It's called aspirin desensitization. And I need to highlight just how intense this protocol is. You start the patient on a leukotriene blocker like Montelukast a full week prior to try and manage that right turn traffic.
Right, to prep the system.
Then, the actual desensitization must happen in an ICU setting with the physician present and adrenaline drawn up and on standby.
Because you are intentionally provoking a severe, potentially life-threatening reaction.
All right, on day 1, they give the patient 30 milligrams of aspirin, wait 3 hours, then give 60 milligrams. Day 2, they push push it to 90 milligrams. By day 3, they are ramping the dose all the way up to 625 milligrams of aspirin.
It's an incredible escalation.
And once the patient survives that grueling process, they taper it down to a massive maintenance dose that the patient has to take twice a day for the rest of their life.
What's fascinating here is the sheer physiological paradox. You are curing a patient's severe, life-threatening sensitivity to a drug by forcefully flooding their entire system with that exact same drug under intense medical supervision.
By constantly bombarding the receptor.
Exactly. You are essentially exhausting the immune system's supply of inflammatory chemicals until it just gives up, resets itself, and finally tolerates the aspirin.
It's like extreme exposure therapy, but with biochemicals. So AER is a massive overreaction to a drug. But the next condition, AFRS, is a massive overreaction to nature. AFRS stands for allergic fungal rhinosinusitis.
The clinical criteria for diagnosing AFRS are very well defined, referred to as the Benton-Kuhn criteria. At its core, it is a type I IgE-mediated hypersensitivity.
I want to make sure we define that clearly. When you say type 1 IgE-mediated hypersensitivity, are we talking about the same mechanism as like a severe peanut allergy?
Exactly. It is an immediate explosive allergic reaction. The body's IgE antibodies recognize a harmless protein, trigger the mast cells, and cause a massive instantaneous dump of histamine and other inflammatory chemicals.
And the visuals associated with this fungal allergy are impossible to forget. During a nasal endoscopy, the doctor doesn't just see normal clear mucus. They find what is specifically described in the literature as peanut butter-like mucus, packed into the middle meatus of the nose.
It's thick, brown, and highly tenacious.
And if they do a CT scan, they look for something called a double density sign, or whale track sign. Why does a fungal allergy leave a rail track on an X-ray?
That radiographic sign is brilliant, actually. The double density is caused by heavy metals. As the fungi sit in the sinuses and metabolize, they naturally accumulate deposits of calcium and manganese.
Wait, heavy metals?
Yes, because those are heavy metals, they block X-rays just like solid bone does. So on the scan, you see these stark white metallic tracks surrounded by the softer gray inflammation of the polyps.
But why is the mucus like peanut butter?
That is what clinicians call allergic mucin. If you look at that brown sludge under a microscope, it is a cellular gradient. It is packed with necrotic dying eosinophils, those heavy artillery immune cells we talked about earlier.
Oh, wow.
And you also find charcoal-laden crystals. These are literally sharp hexagonal crystals formed from the broken down enzymes of the exploded immune cells.
And here's a crucial distinction that the research underlines heavily. This is a non-invasive fungal condition. What does that mean in practice?
It's a vital distinction between an infection and an allergy. In invasive fungal sinusitis, which usually happens in immunocompromised patients, the fungus is acting as an aggressive pathogen. It is literally eating the patient's tissue, invading the blood vessels and the bone.
Terrifying. But AFRS is different.
Right, in AFRS, the patient has a completely normal immune system. The fungus isn't invading anything. It's just sitting harmlessly in the mucus, releasing microscopic spores into the airway.
So the fungus isn't actually attacking the body.
Not at all. The patient's immune system is mounting an apocalyptic response simply to the presence of those fungal spores. The body's immune reaction is causing 100% of the damage, destroying its own sinus tissue, and creating these peanut butter graveyards to fight an enemy that isn't even attacking.
That is incredibly tragic, honestly. The body destroying its own architecture over a false alarm.
Speaking of the body, this clinical data makes a point to connect these localized nasal issues to full systemic diseases.
Yes, the connections are profound. Like, if you see certain types of severe sinus disease, you have to look at the patient's whole genetic makeup. Take cystic fibrosis. 86% of CF patients develop severe nasal polyps because a genetic defect causes their body to produce abnormally thick, sticky mucus.
Which traps every spore and bacteria that enters the nose.
Right. Or Cardiac syndrome, where a genetic defect causes the microscopic hair-like cilia in the body to stop moving. They can't sweep the mucus away, which leads to chronic infections in the sinuses, the lungs, and even causes infertility. It proves that the nose is a mirror for the entire body.
The nasal cavity is never acting in isolation. It is an incredibly sensitive barometer for the systemic, physiological, genetic, and immunological health of the patient.
So what does this all mean for you listening? It means the next time you get the sniffles or feel a bit congested, you shouldn't just think of it as a boring inconvenience. Remember the vast, complex, and highly active ecosystem operating right behind your face. From maintaining the perfect pressure of clear brain fluid, to battling bacteria fortified in microscopic bunkers, to surviving the immune system's extreme allergic reactions. Well, there's a hidden universe working tirelessly to keep you safe.
And it leaves us with a rather profound implication for the future, particularly when we look at fungal allergies like AFRS. Our immune systems are currently reacting violently to the microscopic fungal spores in our immediate environment.
Right.
But as global climates shift and temperatures rise, entirely new species of fungi and unprecedented levels of pollens are expanding their geographical ranges and being introduced into our daily air currents. If our bodies are already mounting apocalyptic tissue-destroying reactions to the ambient spores of today, how will human noses and our hypervigilant immune systems have to adapt to fight the invisible airborne wars of tomorrow?
That is a staggering thought to leave on, a microscopic arms race right at the border of our own breath. Thank you for joining us as we unpack this incredible medical deep dive, and we will see you on the next one.